interventions for them, the process of exploring their experiences can sometimes cause stress or re-traumatize. So I think it's important for us to consider how to protect our qualitative participants. Sound okay? Great. So first we need to talk about what qualitative research is. When I was presenting this workshop before in India, I think I made some assumptions about this being something that many of us have studied, and I don't think that's necessarily the case. So I just want to start at the beginning. Essentially with qualitative research methods, we're wanting to understand behavior from the perspective of an informant, of a participant, maybe your patients. And we're gathering data in the language of the participant. So when we're doing quantitative assessments, maybe we're doing mental health scores, quality of life scores, survey data. Here, the data we're gathering is the way that that participant is sharing information with us. Qualitative research allows us to gather deeper understanding about various social phenomena that we're interested in its natural setting. It can also help us develop theory, and I'll share some examples about this in a moment. Essentially, when we're looking at qualitative research, we're thinking about the why more than the what. Does that make sense? So some ways that we might want to use qualitative research, particularly for individuals like yourself who are providing clinical services or health services, it might help us understand which services are most useful to our patients, or what parts about our services help them or act as barriers to getting them into care or helping them achieve optimal outcomes in care. It can help us understand what pieces of a participant's experience may be most important for us to measure. So, for example, some years ago, some friends and I developed a housing program for people who are homeless and living with HIV in Pittsburgh, where I'm from. And we saw that the program was being very useful to them, but we really didn't know why. So we conducted qualitative interviews to help us refine our interventions, but also to help us determine what elements we need to, what data elements we need to collect quantitatively so we could measure their experiences more in a more appropriate way that's more indicative of their success or failure to exceed their ideal quality of life. And it's also at times useful to use qualitative methods to understand our quantitative findings. So for example, if you see patient scores improve in their, let's just say a quality of life scale, but not all patients improve the same way. If you can conduct qualitative research with some of the patients, you may be able to discern what elements are more helpful for some populations than for others. And ideally, I have to say I'm a big fan of mixed methods research, which is when we pair quantitative and qualitative methods together. So some ways we might do that, as I just mentioned, we might do some qualitative formative research to understand what pieces we want to include in a quantitative survey or questionnaire. It might also help us develop scales to assess the degree of a change in experience. Again, mixed methods can help us contextualize our quantitative findings, asking people to help us interpret what our findings mean. It may also help us develop or confirm theories we have about a state of health or change. Another important thing about mixed methods research is that it can gather information about unintended consequences. But what I mean by that is that we can be doing interventions with patients, we can be doing assessments or surveys with patients, but unless we're understanding what their experiences are like from their perspective, we may miss important pieces of information that we would never know just by going in and asking questions that we wanted to know about. It's also important for us to understand what they think is important in the context of our study or our care. So far, so good? Same page? Great. So here's some examples of some mixed method studies I've done. This is a paper some colleagues and I wrote, and this is the study I mentioned where we developed this housing program. We found a couple years in that it was very useful in helping our patients, our residents, achieve viral suppression, which means a very low incidence of HIV in their bodies, but we didn't know why. So we conducted qualitative interviews with our residents, as well as people that had left our program, because we thought it was really important to understand both the happy and the unhappy situations that our residents experienced. And from this, we were able to pinpoint what elements of our service were most useful to them, and then we could focus more time and energy and resources on those most useful services. This is a study we did in which we were evaluating services at an HIV clinical care setting. And basically the physicians and nurses there felt that their services were really valuable, that their patients were doing quite well, but again, they wanted to know why. So we were able to understand what aspects of the healthcare environment helped their patients succeed in care. And so this study is, I don't think opioid use disorder is a huge issue here like it is in my region of the United States, but it is huge here, yeah. So then you all know what naloxone is, the overdose reversal drug. Whoops, sorry, I had a twitchy finger and I jumped ahead. So we were interested in exploring ways, and if it would be useful to get naloxone, or Narcan, which is the brand name, into the hands of more people who are at risk for overdose. So we did qualitative interviews with a bunch of people who used heroin or had been reversed from an overdose in the past, to ask them if that's something they'd be interested in having at their disposal, and to ask them how we should distribute naloxone to get it to more people, what methods are the most useful. And so then we used that qualitative data to inform interventions, but also to create an agent-based model, which is computation modeling, in which we were able to plot, if we were able to get this many more doses of Narcan out there, how many overdose deaths might we be able to avert? So we found this to be an effective tool to advocate for policy change to make sure we could keep our Narcan funding sustainable. So those are just some examples of some mixed methods work we've done in the past. But again, I will be focusing today just on the qualitative piece, and you can think on your own about how to pair their qualitative work with your own quantitative existing work. So different kinds of qualitative methods include participant observation, where we're in the field seeing what's going on. Interviews, which I think is the most common type of qualitative research. When people talk about qualitative research methods, they're typically talking about one-on-one interviews. These may be with patients or participants, with key informants, anyone that you think will help you understand or answer your research question. Sometimes we'll do focus groups, which is small groups of people. We, much like an interview, we're aiming to elicit some piece of information or pieces of information that will answer our research question, but we're doing this in groups of 8 or 10 people. So when you're thinking about interviews versus focus groups, some things you need to consider are how much time and how many resources do you have. So if you need to get everyone done in, say, under a month, then a focus group may be your best bet, because you can get a lot of people in the room at the same time. You can imagine if you had to do interviews, each interview is going to take about an hour, typically. I would say that's the average. So if you want to do interviews or get information from 16 people, you would need 16 hours just to do the interviews. But you could also do, get information from 16 people in just 2 groups in just a couple hours of work. However, analyzing the data is quite different for interviews, or somewhat different when you're comparing interviews versus focus groups. Because as we'll discuss later, once you have an interview, ideally audio recorded, you almost always need to audio record it so that you can analyze your data. You'll then transcribe the interview and examine the findings from those transcripts. You can imagine how it's different to transcribe 16 individual interviews versus 2 focus groups. The challenging things about transcribing focus groups is that when you have 8 people, 10 people in a room talking, it can be hard on the audio tapes to hear who's doing what. But you also want to think about how you want to use the findings and what's really most appropriate for your audience. So there are some questions that are better suited to one-on-one interviews versus focus groups. These would be questions regarding topics that are very stigmatized, highly personal. You can imagine that some individuals would be less likely to share information about their sexual histories in groups versus one-on-one. On the other hand, there are some topics that really are better suited to groups, focus groups. And that's because sometimes the power of bringing people together to share an experience will get more people to talk. The challenge with that is that typically when you do a focus group, there's one person in the room that's sort of the squeaky wheel. They're talking all the time, and your challenge as a facilitator is to get them to feel like they can keep sharing their feelings, but also elicit feedback from other people so that it's not just one person. Then you're basically doing like an interview with a bunch of people sitting around. We don't want that. So we do strive to make sure that our qualitative methods are systematic so that our rigor is not questioned. And some ways we can improve rigor is by proposively sampling. So if you wanted to understand the value or the experience of some psychiatric intervention you were delivering, you're of course not going to interview people on the street. You're going to be doing interviews with individuals who've been your patients, or maybe were your patients in the past, or maybe are appropriate for your care but haven't entered services. You're intentionally bringing people into interviews that can answer your research question. And some other ways that we can improve rigor, which we'll discuss more at the end of our time together today, is by making sure that we're collecting data in a way that's very intentional and that we're using the same interview protocol with every one of our interviews. There may be some small deviations from the questions as things come up, but we want to be intentional and create a blueprint, sort of a map of what our methods were so that we can accurately describe what we've done. And qualitative researchers love to talk about saturation. So saturation captures the idea that we keep on doing interviews until we feel like we're not really hearing much new information. So there might be one or two sort of blips of information, but essentially if you keep doing interviews, eventually you'll get to a point where you feel like, okay, I understand with this group of participants what their experience is, and I have confidence that I'm actually getting their perspective, their experience. It's challenging because I think especially when you first start doing qualitative research or qualitative methods, you worry that you're not really sure that you're seeing what you're seeing. And I think if you come from a quantitative background, you want it to be crystal clear. You want it to be black or white. You want to know that you have a p-value that shows statistical significance. You're not going to have that with qualitative research methods. Another way that we can improve our rigor and demonstrate that we're really seeing what we think we're seeing is by iteratively analyzing our data. So you don't just read your transcripts once. You're going to read them again and again. You're going to discuss them with your research team. You're going to co-code to make sure we're all applying codes sort of similarly. And we'll talk more about all these methods more in a bit. In quantitative studies, we talk about things like generalizability, right? The degree to which we believe that our findings would be transferred or generalized to another population. But in qualitative research, we talk about transferability. And so this is the idea that we can create a map, or again, sort of a blueprint, so that if other people want to do a study like ones that we've done, we've provided enough information to them that they can carry out similar methods or use a similar protocol, and perhaps have another view of the same experience that you're exploring. And then we also consider in qualitative research dependability, which is the sort of reliability of our findings. And we again try to share thoughts about our dependability by describing the rigor in our approaches. And we also discuss confirmability, which is the idea that if each of us used my interview guide and used my code book, we would come up with very similar findings, which would make us feel like it's likely that what we believe that we're finding is actually true and genuine. And so triangulation is when we are looking at data from different perspectives and sort of comparing, trying to see if we have similar findings. And the most common type of triangulation is methods triangulation. So I might do a mixed method study where I am conducting qualitative research with individuals to understand their experience, but then I might also do a survey or look at some patient records to see if they're having similar outcomes as they reported qualitatively. And that's not to check that those individuals are being truthful. It's just looking at the data from two different perspectives to confirm that we're seeing what we really think we're seeing. But we can also do some data triangulation or investigator triangulation, where we're actually having different investigators do interviews to see if they're eliciting similar findings, or theory triangulation, where we're using different theories to explore our data and understand what's happening. So I have shared with you some examples of some ways that I've done qualitative research. And I think before we move forward, it might be helpful for you to think through what this might look like if you were developing a qualitative research study. So I think it might be good if we all start from the same research question. Say that you were interested in preventing loss to care, so making sure people don't drop out of care or fail to follow up in care, in a community-based mental health clinic. Does that make sense? So people are getting services in the community for psychiatric or mental health conditions, and we want to make sure that they continue in care. So what would your research question be for this topic? And who would you want to conduct interviews with to explore whatever research question you develop? And how would you recruit them? So I'd like you to take 5 or 10 minutes to think through this on your own or with a partner, and then we will come back together and talk through it. Sound good? Any questions about what I'm asking you to do?
Maybe would you kindly keep the slide just to follow?
It's coming back up. Thank you.
Just one question. Is it the lost kids, those people who are drop out from something like intervention?
Yes, exactly. But you can decide if you want to interview people that have dropped out, people at risk for dropping out. But yeah, we want to make sure that people are not going to drop out or understand why they are dropping out.
Why?
patients with chronic schizophrenia are not regular in follow-up. بنحاول ان احنا نشخبطها مثلا مثلا كيس لازم هتبقى في بروفايل في الاخر schizophrenic مثلا لا اصل بره مش
يعني بيحضرون
او
سوشيال
مثلا او حتى او بيحضروا مثلا rehabilitation. ايوه ايوه بيحضروا rehabilitation.
يعني مش بيجي أو دي كيو.
How are you doing? Enough time? Okay. So are any of you willing to share what kinds of things you came up with? Yes, please.
For the research question, we wanted to know why did they drop out or stop coming to the clinic, and then the characteristics. We thought about the age group of the population who dropped out, after how many sessions or after how many assessments.
Interesting.
For how long did they drop out? And then how will we recruit them? Through communication, contact them through inviting them first to come for follow-up, or through emails and phone calls. That's it. Surveys.
Okay. Okay. Yes.
The characters of the patient, I added the number of patients that are still in care,
Okay.
but that are not satisfied with their method. They are about to drop out.
Okay. So people that are unhappy in care would be the people you want to do interviews with to understand.
Plus the dropouts.
And the dropouts. Okay. Interesting. Very good. Thank you. Yeah, so I intentionally picked a topic that's kind of hard because when we're wanting to explore people that have dropped out of care, we've already lost them in a way, right? So I was curious to know if you would think it was fruitful to interview people who are still in care, as well as those who have already dropped out of care. So I'm glad that you thought about people that were maybe less happy in care. I think if I were designing this study, I would do the things that you both talked about, and I would also think about exploring things like, trying to figure out what the barriers are. So I agree with the comment you made about understanding different patient characteristics, because if we find that individuals who are perhaps have lower income are more likely to drop out, that might give us a clue that part of that reason is because maybe they have financial barriers, they can't afford transportation or something like that. But we would want to explore that, right? We don't want to just jump to conclusions. We'd want to understand what those challenges were. Okay, so let's talk for a minute about what it would be like to develop an interview guide. So we want to make sure that when we are conducting qualitative interviews with individuals, we're using open-ended questions because we're able to get much more data from them that way. You can imagine if you said to someone, do you like your care? They could say yes or no, and then it's done. But if you say, tell me about the care that you received at the clinic, that's much more open. And you're giving them an opportunity to share much more. They can't really just say yes or no. They're probably going to be giving you some clues that you can work from about other kinds of things you want to talk about. And it also, I think that once you get people talking, they're more likely to keep talking. So it's really important at the beginning that you not only start with those open-ended questions, but also that you just have a couple of warm-up questions. And that gives you time to, again, get them talking, you establish a relationship with them. I would also recommend that you don't start with really personal, intensive questions or questions that make them feel like you're challenging them. So I was once, one of my very first qualitative studies, I had a more experienced researcher coaching me, and one of the first questions I came up with It was a qualitative exploration of people's experience in an HIV prevention program. And one of my first questions was, what did you learn from the program? And my mentor said, don't ask that question because it's making people feel like you're testing them. If you ask them what they thought about the program or how it felt to them, that'll be much more productive. And she was right. So start with some nice warm-up questions. Tell me about your experiences here, or how did you come here? Anything that's just very broad and will allow them to tell their story. My experience is that people love to tell their stories, even when it's about very personal things like sexual experience, like their histories, becoming diagnosed with HIV. It's incredible to me the amount of detail people will share when they feel like you respect them, which you can assure that you respect them by, again, being open, by not reacting negatively to what they're saying, by maintaining great eye contact, by actively listening to them. All the things that mental health providers, I think, are very good at doing. You want to make sure in developing your interview guide that you are keeping your research question in mind, but you're able to go off subject a little bit if something really interesting comes up. So I mentioned that overdose study that we did where we were asking people about their readiness for community-based naloxone distribution. And we were talking about barriers to getting naloxone. And one person said that I'm not sure how you have naloxone here, but one of the forms we have is intramuscular as a needle. And he said, I don't want the needles around, it's a trigger, I'm trying not to use heroin. So that was a question we hadn't thought to ask. But when he started talking about that trigger, then we were able to explore that with him and sort of go down that path and then ask some other participants if that was an issue for them. So again, we want to stick to our guide as much as that we can, but also have the freedom to explore something interesting as it arises. It's important to learn your cadence, your rhythm with your participant. So you have someone who might be a very, like me, a faster talker, or someone who's very casual in the way they talk. It's sort of like mirroring, like the therapeutic approach of mirroring. You want to try to speak in the same degree of formality or informality as they do. You want them to be comfortable, just like you would with a friend, right? You're engaging and helping them feel like it's a shared conversation, not a one-way conversation. The beginning of the interview really sets the tone. It tells them what to expect. Again, if you're very open and interested and give them time to tell your story, then that sends them the message that you're really wanting to hear from them, and they're more likely to keep sharing with you, their information with you. But also as you're interviewing, you need to pay attention to the overall story. Make sure you're always thinking, like, what am I not knowing? What am I hearing? What's coming up here? Be familiar enough with your interview guide, your list of questions, so that you can jump around in order. So if you're asking people about their experiences in the HIV clinic, and then they start telling you about what experience was like at a different clinic, you may have that question at the end of your protocol, where you're asking them about how experiences were different in a different clinic. You would never want to say to your qualitative participant, no, I'll ask about that later. Let them talk. Let them talk in the order they want to talk, right? Just go with it. It's perfectly fine to, so long as you have that main research question in mind, it's perfectly fine to go off track and just make sure you keep circling back to the questions you were meant to ask. And it's also quite all right throughout the interview or at the end of your interview if you say, just give me a second here, I want to make sure I didn't miss anything, and then you can refer back to your guide. The ideal, though, is that you are familiar enough with it, you don't have to be constantly checking. I once did a qualitative study with a colleague who had not been trained in qualitative research methods, and when I listened to her first interview tape, she said, okay, first question, how did you become infected with HIV? Great. Second question, who did you tell about HIV? It was a survey, it wasn't a qualitative interview. No shame to her, she didn't have, this training, qualitative training, but the idea is that it's not a survey, it's an interview. Yes?
Do you have some tips for the phone call interviews?
Phone interviews. So, I don't know that I have specific tips. I would say you want to try to connect. I think it's harder to connect over the phone. It can certainly be done. I haven't done much phone interviewing, and certainly not with more intimate personal subjects like mental health issues or HIV. Let me think about that. I'll try to have that work in the background. Thank you for asking. Just a little suggestion we like to share is that when you're done, so when you start the interview, you're going to ask for permission to audio tape the individual. And then when the interview is over and you say, okay, thank you very much for your time, it was so great talking with you, leave the tape running a bit. I'm not trying to say that you should be sneaky about it and hide the audio tape. Just leave it running. Leave it on the desk. Make sure it's still on. Often when people feel like the formal interview is over, they'll share something else, and you don't want to miss that data. Again, don't sneakily ever audio tape someone. People legally need to be informed that they're being audio taped. But it can be very helpful to leave the tape running longer than they think is necessary.
Excuse me, can you summarize this at the end, and after the taping the interview, you can summarize what happened to the person you are interviewing. You can summarize what happened.
To the individual?
Yes, at the end of interview, and you gain the data you want. At the end, to feel confident, you must summarize what happened in the interview. You say to him, I know from you that so and so and so and so. This gives confidence to the person you are interviewing.
Right,
This
so
is
you're
my
confirming,
point.
yes, thank you. So you're confirming that you heard what they said, that you've heard it correctly, you accurately captured what they shared with you. I think you're right. I think that confirms to them that you've heard them, but also confirms to you that you've heard them right.
Yes.
Yes, yes, yes. I can turn it off. It's so loud behind me. It's okay, it's not.
حد يشغلهم من بره كويسة.
Okay, that's all right. Okay, leave the tape on, running. When you've completed your interview, before you leave the room or before you go very far, jot some notes to yourself about what happened, anything that stood out for you that was particularly striking. Describe the person, describe the setting, your main impressions. And this is a good time also to collect any demographic data that's important for you to know. So people's race, their ethnicity, their age, their gender, sexual identity, anything that you think is critical to your research question. This is a good time to record that. I would never start a qualitative interview with asking those kinds of demographic questions because it just makes people feel, again, like they're being studied rather than listened to. Some other tips and tricks, let the person talk. This is not the time to correct them. They could tell you something that's wildly wrong about their medication, about their diagnosis. This is their time to talk. They could say something that feels very politically incorrect to you, something you don't agree with spiritually or religiously. You're there to listen to them, not to collect them. You can practice qualitative interviewing skills in everyday life. You can just listen to people on the street, in your family. Active listening is sort of the root of good qualitative research. And there's this great thing called the ethnographic pause, which is when you ask someone a question and maybe they answer quickly and you don't really feel like you've heard everything or listened to everything. So you just wait longer than you might. And I think in everyday conversation, we all have sort of social expectation about how quickly we respond. And so when someone else is clearly done talking, we're more likely to jump in and say, oh, yes, 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 I see. So you might do that, or you might just listen for a minute. Because often when you create that silence, people will share more or share something differently. It's another way of indicating that you want to hear what they have to say. But you're in charge, so you do have responsibility for not only guiding the interview and getting to the questions that are important to you, but also setting expectations about the expectations they'll share with you, about how the interview is going to go overall. And so also with regards to expectations, of course, we have an expectation of confidentiality. So for our ethics review board, qualitative interviews are often exempt from full board review, but they still are reviewed by they're still examined by our institutional review board, but the board does not review our data on an ongoing basis. I'm not sure if that's the same for you or not. Regardless, there are rules around the way that we collect qualitative data, the way that we protect qualitative data, and we are very responsible for protecting the information that we gather from people, which is often very personal and intimate. So this can be things like making sure that our data, our transcripts and our audio guides or audio tapes are placed in locked filing cabinets. It means that when you transcribe, oh, thank you. I feel like I'm not yelling in my own head. Thank you.
خلاص يا حسام مش عايزين اكتر convenient كده يا
Thank you. It also means that when we have an audio tape of an interview and then we move to transcribe it. When you get that transcribed, typed up, it's important that we remove any identifying information. So if an individual who participates in an interview shares their name or the name of their partner or someone else in their life, we don't want to transcribe that. We have that redacted.
Just one question.
Mm-hmm.
Why you prefer audio tape than videotaping?
Videotape can be okay. It can give you much richer data in some ways because then you can analyze not just what you're hearing, but also what you're seeing, the way people are reacting. I think it can be more expensive, and I think it can also at times make people feel a little more uncomfortable. Yeah, but there may be a setting where that's more appropriate, so it's also an excellent method. Also consider the fact that holding people's stories can be really intense. So after you do a lot of interviews with someone who's, with individuals who have experienced trauma, often you may feel you've taken on some of that trauma, that secondary trauma, right? So you need to make sure that you have ways of confidentially sharing your experience of interviewing people, that you have someone who can help debrief you, a supervisor or a colleague. However, this is not the time. You don't share these stories at parties with your friends, with your family members. It's confidential data, just like any, medical health record. If you feel like someone's in danger, if they're expressing something during an interview that makes you feel like they're in danger or they're endangering someone else, you do have a responsibility to alert your supervisor or whatever your protocol would normally be if that kind of risk came to your attention otherwise. Again, be very careful with the way that you handle audio files and transcripts so that they're protected.
Maybe for this, like a form of breaking confidentiality, someone is in a danger or can cause danger to someone else. In this case, we break this confidentiality. Or, we can notify to somebody else, not just to follow up.
You can or you cannot? I'm sorry, you're saying you can?
I think we can break
Yes.
confidentiality
Yeah.
at this point.
Yeah, so when you, one thing we didn't talk about because we only have 2 hours together today is that when you develop your interview, your research protocol, your qualitative research protocol, you'll also you'll have a verbal consent, at least for us it's a verbal consent, and in that consent you would describe what would happen if you had to break confidentiality. So anytime we're doing a study where someone indicates they're suicidal or where they are threatening harm to someone else or child abuse, we need to make it clear ahead of time that those are instances where we would have to report, where we would break confidentiality for issues of safety. Yeah, thank you, very good point. So again, you can practice interviewing in the real world. Listen, this is just a picture of all the people that you could be interviewing, except maybe the dog. I don't know, I've never done an interview with a dog. I don't know how I would transcribe or analyze that. But there are people all around us we could think about actively listening to all the time. Your Uber driver, your mom, your grandmother. Just ask questions, pay attention. And I think the key to being a good listener and thus a good qualitative researcher is being really intentional about the way you're listening and eliciting information from people, which I have to say is becoming a lost art. I feel, at least in our culture, in America, people like to talk more than they like to listen, and it makes me sad.
I think everywhere.
everywhere. Very important.
But the issue is that the limit for this, is there a limit for letting the people talk?
Well,
Because if we keep on listening for how long?
yeah. So I think most, we strive to have most interviews take about an hour. I think once you go past an hour, depending on how many questions you have, it may start to feel like you're going in circles. Your responsibility is to keep it somewhat on track, and that can be really hard to make people feel like you are still listening to them when you're really trying to cut them off. It takes practice. One thing I like to do in those situations is say something like I'll change the subject in the middle of what they're talking about after I feel like they've started going in circles. So I'll say, oh, it's so interesting that you're telling me this, but what about this? So you're like both reinforcing, oh, this is so interesting, it's so great, I'm glad you're telling me, but I want to know that, right? So it's different from just saying, stop telling me this. You're reinforcing your interest and then moving on. But sometimes you just have interviews that go on and on and on. And sometimes you have other interviews that are very, very short. That's why we never interview just one person, right? The average we want to do is typically around 20. But again, we kind of keep going until we have that idea of saturation.
And the person who is interviewing is the same one who is transcripting the data?
That's a good question. So the question was, is the interviewer the same person transcribing? They can be. I will say that when I transcribe my own interviews, I feel like it gets me much more familiar with the data, but it's incredibly time consuming. So for every hour of interview, audio tape, it can take you about an hour to type that up. There are also some great transcription services. One is called Rev, R-E-V, as in victory.com, and you can pay to have them transcribed. You can hire a student to help with transcription. But it doesn't have to be the same person, no. We do want to work from a guide, though. Yes?
Doctor, in breaking confidentiality, do we have to alert the supervisor or a family member?
In interviewing a child?
Breaking confidentiality.
Oh, breaking confidentiality. You know what? I'm not sure what your rules would be on that. I mean, I'm guessing you have policies now for when you have to break confidentiality in the course of treatment. Yes? No. Oh, your student. Yeah. Can anyone else help out with that?
This is part of the law for ethical consideration of the patient. Confidentiality is one of the main items that we have to respect. But we have rules when to break this confidentiality, even if I have an informed consent or an assent from this. When he is in danger, he himself, or he can cause danger to others, or if he had a disease that can affect others,
Interesting.
or threaten his life. So in all these cases, we have to break the confidentiality, and it depends definitely whether we are going to conduct this information to the caregiver or the one in charge, or to the institution in his institution. Because, for example, if a patient has suicidal tendency or suicidal, we have to announce that this patient has a risk for suicide.
This was a caregiver.
So the question is, who do you report to, right? Yeah. So it sounds like you would report to the parent if it was a minor,
Yes.
but also
For the kids, we report
supervising
the parents,
psychiatrist?
and even for the adults, we report to the family.
You would report to family. So I think we
For
probably
example, can alert her or his partner?
to their partners. I think it's probably different based on where you are. I don't think that we would disclose to a partner. If they were a minor, we disclose to the parents and to a clinical supervisor, their provider, the clinical provider. I don't know about disclosing to partners. Is that what you do?
No, the issue is that I think if the caregiver, the main sponsor for this patient is the husband or the wife,
I see.
the person in charge or responsible.
Yeah.
In this case, we break the confidentiality for the caregiver.
So excuse me, do you mind pushing the door shut? Thank you. So the thing is that in your case, you're mostly talking about patients, so you have protocol already for when you can break confidentiality and how to do that. I think in my world, I don't treat patients, so I'm likely to be interviewing sort of a person that I've either recruited for my study, a person of a program. I don't know that I would always have protocol in place for that individual, indicating who I could break confidentiality too. In my case, it'd mostly be reaching their provider and asking them to step in and help. I do have a little case study about responding to these situations later. Okay, so let's talk about how to develop your interview guide or your questions. You do want to have sort of a semi-structured guide. So we have a set list of questions we're hoping to get through in most of our interviews. But again, not a survey, it's a guide. Our questions are open-ended, so we can elicit lots of great responses and details. You want to include the same set of questions in all your interviews because that's how we can, again, confirm our data across participants. But you don't have to ask the question quite the same way every time. It's not necessarily word for word. You're getting to the point about it, right? Tell me about your services. How do you like your care here? You know, kind of the idea of the question, not necessarily reading it off. You don't want to read it off a sheet. We also like to build in prompts. So if I say to someone, you know, what'd you like about your care here? I'm sorry. Yeah, you can say, what'd you like about your care here? What was your experience like here? You want some follow-up questions in case they don't really tell you much, right? So they could say, oh, that was good. Have some questions ready to pull out some more questions. Tell me what was good about it, you know? How did you feel about your providers? What's the setting like? Make sure that you have additional sub-questions or probes to get to the meat of the question that you really want to know about. You want to build your interview questions around what you want to learn, what your research question is, but also about what you already know, including that which is from the literature. So if you know there's a theory of intervention or an evidence-based practice out there, you're interested in understanding how that affects your participants, you might build your questions around all that other researchers have done or you've done in a previous study, and you're just adding questions to it. You want to think about the scope of the questions, like how broad you want to get your questions, and how long do you want it to be. I think it's hard for people to do interviews longer than an hour, so you don't want to have 25 questions. You'll never get through them all. So these are all ways to sort of make your guide work for you. It's also fine to test your guide on a couple participants, right? So you could do sort of 1 or 2 test interviews, and then if you feel like there are some questions that need to be tweaked, you can tweak those questions and then do them with the rest of your participant group. Keep those questions open, plan some probes. So here's an example for you of how we developed an interview guide. I'm doing a study with a street medicine provider. So they provide medical care to homeless people who are living on the streets. And we want to understand people's experiences of care. What was their care like? So these are some of the questions we're asking. Tell me about your experience with the clinic. How long do you receive services? What kind of things do you like to get here, or do you get here? So this is like the main question, and we have some probes there. We also think from the literature that there's something about the autonomy of their care that makes it really user-friendly. So they're able to make decisions about their medical decision-making, about whether or not they go into traditional services. So rather than practicing care in a very top-down way, these patients are included in their own decision-making. So we wanted to explore autonomy based on previous studies. So we have the question, who makes decisions about your health goals? What kind of goals are set? What happens if those goals aren't set? So I'm really interested in this whole field of research, which is sort of client-centeredness. It is client-centeredness. It's not sort of client-centeredness. I believe that care is much more meaningful to people when they get a say and how that works for them. So we're trying to explore what that's like in this medical street medicine program. And we also feel like social support. We're curious what that's like. So this medical program, street medicine program, seeks to help people exit the streets, to get them into housing programs, but we're not sure what happens for those individuals. So if they have a whole community of support while they're living on the streets, does that change? So we have a question here, what was helpful for you in transitioning to housing? Very broad question. What we really wanted to know was what social support they got. So we have a probe here. Do you still visit your street family? Do you still see people that you were close to when you were living on the street? Do these examples make sense or help clarify at all? Would you tell me if they didn't? Hopefully you'd ask the question. All right, so let's start practicing drafting some questions. Again, we'll take 10 minutes for this activity. Again, we'll use the same study. You're interested in preventing loss to care in a community-based clinic. So refer back to the research questions you had in activity 1, and then think about 2 separate domains or areas you want to explore. Two categories of questions you'd ask related to the overarching research question. And then think about what a couple questions might look like for each of those domains. Sorry, sometimes my clicker stops working.